I'll tell you on the side that the American Society of Blood and Marrow Transplant just voted at the conference I was just attending as a member, voted to change their name to the American Society of Transplant and Cellular Therapy, because there is so much going on with cellular therapy that they're absorbing that as part of their expertise area, and they anticipate being so many new products for cellular therapy coming onto the market that they voted to change a name that's been out there for like 100 years. So it's not just transplant anymore, and it's not just going to be CAR T. There's so much going on with modulating different cells ex vivo that I think that by the time you're in practice or in 5 to 10 years, a lot of what I say is going to be outdated. There's going to be so much more you're going to have to potentially to learn on your own or become familiar with. So what is the point of immunotherapy? So we want to either enhance or renew normal immune functions to try to identify the cancer cells as foreign and eliminate them, right? So normally the immune system looks at tissues and markers and anything in your body to say, are you me or are you not me? Self or non-self? Oh, yeah, you're self, you can stay. You're not me? Nope, you can't stay. And then depending on what cell we're talking about, either does something specific to destroy it or flags down other cells to come and destroy the foreign particle. That's how we fight off viruses, it's how we fight off bacteria, and it's how we're supposed to fight off cancer cells. We notice something is abnormal or not fully celled, and we flag it for destruction, we destroy it. But the cancer cells become smart and figure out how to evade it. They downregulate their different markers, they upregulate normal markers. They can downregulate different immune cells by secreting different factors. So how can we use immunotherapy to overcome those resistance mechanisms or to enhance the immune cells that we already have? So we're going to talk about all the different ways in which we can do that. But before we do that, you really have to go back and remember the basics of immunotherapy, or the immune system. We have an innate immune system and an adaptive immune system. So your innate immune system is your immediate, non-specific response. These are things like your macrophages, your NK cells, your dendritic cells, your antigen-presenting cells, and they can stimulate the complement and cytokines. And these don't result in memory, right? These are just an initial frontline response, one and done. Versus your adaptive immunity, as adaptive term means, these are very pathogen-specific, and they do provide or come from previous lasting memory. And these are mostly your lymphatic cells, right? Your T cells and your B cells. Your B cells are what produce antibodies, and your T cells are what provide cell-mediated response. So just kind of as a refresher. Again, if you're a visual learner like myself, you really got to look at some graphs for this. So on the left-hand side, I think this image is really helpful. So you're exposed to an antigen, whether that's, again, a virus, a bacterial particle, or a marker from a cancer cell. The antigen-presenting cells, such as your macrophage, engulf that antigen, processes it, says, "Oops, you're not normal. You're not me. I'm gonna give you to somebody else to do something." And so the antigen-presenting cell presents the antigen to your T helper cell, and your T helper cell says, "Oh yeah, okay, I don't know you. You're weird. You're foreign. I'm gonna do something about it." And it then recruits cytotoxic T cells and B cells so that they can do something. So the T helper cell is just kind of like a middleman, right? You just like give it to somebody else. And your cytotoxic T cell, as the name suggests, is going to kill off whatever that bad thing is. And your B cell can give rise to plasma cells to secrete antibodies so that the next time you're exposed, on second exposure, your memory B cells know what to do and secrete the antibodies to get this cascade going faster, right? So you can see how your antibody-mediated and your cell-mediated work together. They interact with each other, and then they can provide that lasting immunity in the future from memory cells and from antibodies. That's normally what happens. So if the cancer cell somehow can reduce the antigens it's presenting, or if it can turn down T helper or cytotoxic T cells, it's going to inhibit this process, right? So we need to find drugs or ways to overcome those problems. And on the right-hand side, is a little bit more complicated of a graph, but basically you have your dendritic cell, which is another type of antigen-presenting cell. So it engulfs, here's allergens, which is the best picture I've come up with from a derm thing, but pretend it's an antigen, it's the same thing. Pretend it's a cancer antigen. Engulfs those, secretes particles, and presents that antigen to, again, your T helper cell. Your T helper cell then can recruit your cytotoxic T cells. And again, there's all of these different cytokines and complement that are secreted by these cells to stimulate the other cells. So how does your T helper cell get the cytotoxic T cell to show up? It has to secrete things immune system in a very small nutshell. It's more complicated than that, I realize that, but I just wanted to kind of overview it. So how can we intervene at different points here? So one thing we can do is augment the immune cell function. So we can provide exogenous things like interleukins and interferons to turn up and recruit more cells, right? So those are the biologic agents I referenced earlier that I said they're not really that effective, because they're just not. Then we can target cells specifically to recruit immune processes. So we're going to talk a lot about monoclonal antibodies. They're really important. Monoclonal antibodies can also be conjugated to a cytotoxic agent, which is called payload delivery. We're going to see that in a few slides. And then we have what's called BiTE therapy that I'll also go through in detail. And at this conference I was just at, there are some investigational drugs they're calling DART, which is similar to BiTE but more structurally stable and a little bit more effective. So again, as you go into practice, there can be more things I'm not talking about today that are going to be highly clinically relevant because this field is just moving so fast. We can also provide active T cells. So this is allogeneic stem cell transplant. We get cells from a donor, we put them in a patient that needs them, so that those T cells can provide a functioning immune system to fight off the cancer. And then CAR T I mentioned is chimeric antigen receptor T cells. So we take a patient's T cells, modulate them in the lab to enhance them, and then put them back to let them function a little bit more effectively. We can also try to increase internal T cells through vaccination. These efforts haven't been all that successful, but there are a lot of clinical trials still ongoing in an attempt to try to be able to do this. But unfortunately, it just hasn't really been the success that we wanted it to be. And then importantly, we can use drugs to prolong the activation of T cells. So modifying the regulatory mechanisms through various therapies is definitely a hot part of immunotherapy now. So kind of thinking back to that graphic, we can provide exogenous biologic agents to enhance the recruitment of cells. We can target the cell surface markers on the cancer in order to stimulate cellular death by recruiting immune cells directly to the tumor milieu. We can provide exogenous T cells, or we can enhance endogenous T cells through vaccines, or we can turn on and off T cell signaling in order to overcome the dampening of T cells that can happen from cancer secreting different chemicals to turn off the T cells. So let's go through each of these kind of in sequence. Actually, are there any questions on this overview? Because I'm about to go into each one, so if this doesn't make any sense kind of now is the time to say, hey, can you re-explain that? Which I'm happy to do, because I know there's a lot going on here and it's a little complicated, but I guess I should give you guys a second to make sure nobody's like, what? Okay, just wanted to make sure, because otherwise we're going to kind of blow through the rest of it. I don't want someone to feel lost. So the biologic agents are things like interferon alpha and interleukin 2. These have been around for a long time, and to be honest, they're really not that effective. They have some niche markets where they still can be used, but fortunately we've come up with better therapies for most of these cancers, and we really don't use these agents a whole lot. I'm not going to test you on this slide because they're not used that commonly. I don't think it's a good use of your time to remember all of this, but I wanted you to realize that we can give biologic agents to mimic current normal immune responses in order to upregulate the adaptive immune system to target the cancer. The problem is there are a lot of limitations to these. The cancer cells know how to turn down these chemicals, and they know how to avoid them. So poor trafficking to the site of the cancer and negative immune modulators that the cancer secrete to overcome this really have limited their effectiveness. So it sounded like a great idea at the time, but it really didn't work because of the tumor biology. And the side effects were huge. So I'll just tell you, IL-2, you have to be a specific registered center to give interleukin 2 in the hospital. These patients are admitted directly to the ICU to get this therapy. Like, we don't even put them on the floor and transfer them. We just put them in the ICU to start because we know it's going to be a problem. So how many patients want to sign up for that, right? Like, this doesn't sound good. Because they do have something called capillary leak syndrome that can be fatal. And so you see remissions about 10%, and admitted to the ICU to get this therapy. The risk to benefit, just unless you've exhausted all your other options, really isn't worth it. So biologic agents are extremely limited, but they really were the first thing we tried that stimulated our understanding of how we can interplay with the immune system and what things we need to overcome that the cancer is doing to avoid the immune system. So it really helped us understand and move on to the more effective therapies we're about to talk about. So monoclonal antibodies were some of the first other targeted agents other than our oral targeted agents, other than our small molecule inhibitors. Monoclonal antibodies again hit the markets in like the 1990s. They really kind of revolutionized got them in print on the next slide, so I don't feel like you need to rapidly write down what I'm saying because it's all there. So one of the most common mechanisms that monoclonal antibodies can impact are direct cellular killing. So a monoclonal antibody is going to target a cell surface marker. For example, many lymphomas express CD20 or cluster of differentiation 20 on their cell surface. So B cells all express that. So if you have a B cell malignancy, you're going to express that marker. So we can target that cell with a monoclonal antibody. So your normal other cells that don't express CD20, this monoclonal is not going to attach to them. It's not going to do anything. So it's a more quote-unquote targeted therapy because it only goes to the cells that express that surface marker. So the ones that cause direct cell killing are going to attach to that marker on those specific cells, and they are going to either antagonize or agonize that receptor, depending on whether you want to turn off or on the cellular cascade. So if you have a mutated HER2 that's causing too much proliferation, you want to antagonize that. You want a HER2 inhibitor because the HER2 is normally causing too much growth, so you want to inhibit that. Versus in some other cases, you want to turn on something that would cause apoptosis. So it depends whether it's agonist or antagonist, depends on what the transduction leads to, depending on that disease. So that's going to cause direct cell killing just by binding it and turning on or off whatever that signal pathway is to allow for apoptosis. So that's one way in which they can work. I mentioned earlier that some of these monoclonal antibodies can be conjugated to either a cytotoxic agent or to radiation. That's called a conjugated antibody or an antibody drug conjugate, an ADC. This is what we call payload delivery. So that they're the same kind of monoclonal, so they attach to whatever cell surface marker, they're engulfed into the cell, and then they release whatever they were conjugated to, either radiation or chemotherapy agent, and then that has its effect inside the cell. So rather than give systemic radiation, we give radiation just to cells that express that marker. Or we can give the chemotherapy drug not to all cells that it gets into, but only the ones that express that marker. So we reduce a lot of the systemic side effects by doing this. That doesn't mean we get rid of all the side effects, but we get rid of some by doing that. So payload delivery or antibody drug conjugates are another way to cause direct cell killing in that mechanism. Now, we can also impact what we call the tumor milieu, or the environment right around the tumor. With monoclonal antibodies, this isn't the most common, but some of them can attach to like stromal cells and the vasculature around the cancer and kind of inhibit their ability to grow and invade kind of the nearby tissue. Again, that's not the most common, but I didn't want to not say it because it is something that's out there. Other ways in which monoclonal antibodies work are immune-mediated tumor killing, which are all shown in the graphic part B, but there are several pieces to this, so I feel like it's a little easier on the next slide to kind of go through one by one and toggle back and forth if you don't mind. So one of the mechanisms of immune-mediated is induction of phagocytosis. So that's shown in part B at the top left. So the monoclonal antibody, again, attaches to that cell surface marker, and it recruits things like macrophages that can then cause phagocytosis of the cell. So it attaches to the cell and recruits immune cells to come and kill it, right? It doesn't do anything with the signaling like we saw in direct cell killing, but it recruits an immune cell and says, hey, I flagged this, come and do something about it. So that's the direct immune-mediated mechanism. The next is activation of complement. So it can recruit things like complement or, again, phagocytes to target the cell to be killed. And so we see that kind of in the top right with the complement, the NK cells, and the T cells. So again, it can just kind of recruit the immune cells or turn on different cells, different local signaling like complement to get the immune system to show up to the tumor bulk or show up to that area and then kill off the abnormal cells that way. And then the last way, which is one of the most common, is antibody-dependent cellular cytotoxicity, which in some literature is called antibody-dependent cell-mediated cytotoxicity. They're the same thing, there's two different terminologies that keep it interesting. And this is where you recruit immune effector cells to bind. They release proteins and kill off the cells. So we see that kind of on the top right where it says ADCC. It's recruited your natural killer cell. It will secrete some granzymes and perforins and then get into the tumor cell and make sure that it leaks proteins and dies. So that's one way. So these two slides kind of take a minute on your own to kind of reread and re-review. There's a lot of monoclonal antibodies out there. Really understanding these mechanisms, I think, is important, and they can be quite complex. So an important thing also for pharmacists to know know is the nomenclature. This might seem a little basic and boring, but you will get asked by physicians about how things work, and you should be able to dissect a name of a monoclonal antibody and know this. You shouldn't have to look it up because it's in the name. We have a naming system that helps us understand. So for example, rituximab is TUXI. So we know that this targets the tumor, and it's a chimeric. So in the top right, you see what chimeric is versus humanized. It's just how much of the monoclonal is human versus how much is something else like mouse or primate or whatever. The most important ones to know, just a star for studying, U is human, XI is chimeric, XIZU is humanized chimeric, and ZU is humanized. You should actually know those. And the reason for that is if it's fully human, you're going to have less infusion reactions because it's fully human. If you're chimeric or only humanized, you may have more infusion reactions because that whole monoclonal is not fully human, so you're going to have potential risk for more infusion reactions. So knowing what it's from really does correlate with how we prophylax patients for infusion reactions and how many infusion reactions and how severe they can be. And that's not to say fully human ones don't cause infusion reactions. That's not true, so don't let me mislead you. But it does kind of correlate there, so it's something to think about.
Dr. Clemens?
Yes.
What's the difference between human and humanized? Did you say that?
So humanized and chimeric humanized, the XIZU actually is really uncommon. I can't think of one off the top of my head, at least that I use. But it's I don't have a picture of it, but it's not fully chimeric, so that last little part of the fab is not fully human. And then it's also, I'll have to find a graphic and post it on ELT, but I don't think I can verbally explain it. I'm much more of a visual person. So I might just add a slide to show you, because I didn't put it on here because it's not a common one, but I have to put a graphic up to really show you the difference, if that makes sense. So I'm not trying to explain it verbally. I'm much more of a visual person. The systems that they target, the ones that are important for oncology are obviously TU for tumor, and so that's probably the most common one. You will have monoclonals outside of oncology. So there are some that are that target bacterial, some that target cardiovascular. LI is immunomodulating, so we do see those in oncology quite a bit. And toxin is TOX, so we do also see those as well. So that's kind of just something to think about when we're reading drug names. You should be able to figure out a little bit about it, its structure.
Dr. Clemens, when you mentioned some of the abbreviations and the nomenclature, you had said the important ones for us to know were U for human and XI for chimeric, and then you mentioned a couple more, but I didn't catch those.
It's just the last four in that list. U for human, XI for chimeric, and ZU for humanized. Those are the three most common. So those are the three I think you should know. Mouse being O and other things, those are more preclinical. I don't know of any out in practice that are actually directly from a hamster. Like, I don't think that happened. But it's just on here for completeness sake, so that's why I wanted to tell you the ones you should know so you don't waste your time studying things that aren't clinically relevant. So U for human, XI for chimeric, ZU for humanized. Those are the three to really know. And then TOX for toxin, TU for tumor, LI for immunomodulating. Those are probably the most clinically relevant for our purposes here. So here are a list of some of the most common oncology monoclonal agents, their targets, and then again their mechanism. And I just put their indications in general for you. You're going to get these in your future disease state lectures, so this isn't something that I expect you to know that bevacizumab is for ovarian, colon, lung, brain, and kidney. Like, I'm not going to test you on that off this slide. You're going to get that in future lectures, so I just want you to kind of know when to expect to hear more about these. And you will learn when you do these drugs in the disease-specific modules why they have the target. So I already talked about CD20 is common in lymphoid malignancies, so that's something you can expect to see in my lecture upcoming for that. So where they target is important to know. So that's the only thing off this slide I would really test you on. So knowing, rituximab is a CD20, that's something you need to know. And then as you learn about the diseases, it'll make sense why we use it in certain diseases and not others. And then at the bottom, I've pointed out the ones that are those payload delivery, the antibody drug conjugates. There are a few that deliver radiation, as I mentioned, and some that deliver cytotoxic agents. And so I listed those here for your reference as well. So those are your antibody drug conjugates, your ADCs, and those you should know. They're usually two names, so that helps kind of remember them. But those you should know are delivering a payload because that's a different mechanism than your other monoclonals. So the drug names to what target is what's testable off of this, and which ones have payload delivery is important as well. So that's what you should take home from this slide. Okay, so moving on from our monoclonal antibodies, let's talk about other, how can we target T cells specific? So we saw in that graph that we went through that T cells are really the crux of how the immune system is activated. So you have your T helper cells that receive the antigen from your antigen-presenting cells. They can turn on and stimulate your cytotoxic T cells, and then you can create some memory T cells. So T cells are a very important point in how we can impact cancer therapies. So how can we do things? So I already mentioned we can inhibit, T cell inhibition receptors can be blocked to allow T cells to remain active. So normally T cells, just like everything else in the body, we want to get back to homeostasis. A T cell is turned on, the body's going to have a mechanism to turn it back off again, right? That's normal. So we never want something to get out of control. That's what happens in your, kind of like your rheumatoid problems and psoriasis and other problems in the immune system that can cause diseases if your immune system's out of control. So the body normally turns the immune system off naturally. We don't want that to happen. We want it to continue to work and fight the cancer. So we want to turn off the off signals to keep the T cells on. And that's our CTLA-4 and our PD-1 that we're going to discuss in a second. We also have the BiTE therapy I mentioned, and this is can we specifically direct a T cell response to the cancer B cells. So right now, BiTE therapy is only effective for B-specific antigens, so B-specific cancers. So BiTE therapy can direct a T cell to a B cell and kill it off. And then we can deliver and enhance exogenous or endogenous T cells. We talked about vaccines, allotransplant, and CAR T already. So I just kind of put these in buckets so you kind of think about them that way. So let's talk about these specific markers. As I said, T cells are turned on. They do their thing, and then they'll upregulate different cell surface proteins to turn themselves off, right? So one of these is CTLA-4. So a T cell that's activated and doing its thing, it's going to upregulate CTLA-4. That's going to bind your antigen-presenting cell, and it's like, okay, the T cell's done its thing, I'm going to turn you off now. You're done, you can go back to being quiet. So that turns the T cell off. That's not what we want. We want the T cells on so they can continue to fight off the cancer. So this is really, commonly described as the brakes on the car, right? The CTLA-4 are the brakes on the T cell. It's going to turn off the immune system naturally. So we don't want that to happen. So we're going to provide a monoclonal antibody that's going to bind the brake on the car and let the T cell keep going. It lets the T cell keep being active and fight off the cancer. So a CTLA-4 inhibitor, a monoclonal antibody such as ipilimumab, turns off, binds the brakes on the car and lets it keep going. This is very similar to our PD-1 inhibitors that came on the market after CTLA-4. So PD-1 is another T cell surface marker that is upregulated in activated T cells that binds the antigen-presenting cell and turns off the T cell. So it's another way the T cells are supposed to be regulated so they don't overdo it, because that can cause autoimmune diseases. So the body's trying to do the right thing, but in this scenario, it's not helping. So again, we can have drugs like nivolumab and pembrolizumab that bind the PD-1 and block it, therefore leaving the T cells activated so they can continue to fight off the cancer. So CTLA-4 and PD-1 inhibitors, turn off the brakes on the car and let the T cells keep going. So you can kind of imagine if we're letting T cells go and go and go and go, and we're circumventing the normal method of turning them off, what's going to happen? We're going to have adverse events that are immune mediated, right? We are blocking the normal mechanism to get T cells to rest. We're letting T cells go and go and go. Well, we're letting those T cells go, but they aren't 100% specific just to the cancer, right? They're going to affect the rest of the body, unfortunately. So by turning off the brakes on the T cell, letting them go, we're going to have some outside side effects. And these are called immune-related adverse events, or IRAEs. Sometimes it's called immune-mediated adverse events, or IMAEs. All the same thing, it's just terminology. And so the timing and onset varies for different organs. You're going to get a lot of this in your solid tumor lectures. with Dr. Saunders upcoming, so she's going to spend much more time on this. It's really important to understand. So patients that are on CTLA-4 and PD-1 inhibitors, they're not going to get your traditional cytotoxic side effects. They're not going to get myelosuppression and whatever. They're going to get these immune-mediated side effects. And so these patients can present and look a lot like somebody with an autoimmune disease. So things like Crohn's or ulcerative colitis, they present with a lot of diarrhea and colitis, right? So you're going to see things like that. Some of the most common immune-mediated adverse events are diarrhea and rash and pneumonitis, but technically can affect any organ system in the body. Some of them require dose modifications, and sometimes you have to stop therapy because it's so intense or severe. Because it's an activation of the immune system that's causing these problems, you can imagine the way we treat it is to turn slightly down the immune system to things like corticosteroids. And so, again, you're going to get a lot more of this with Dr. Saunders, but I did want to touch on it because I think it's important to correlate the mechanism of the drug with its toxicity, because these should make sense to you. They should go together. So let's talk about those BiTE therapies. So BiTE stands for bispecific T-cell engaging antibody. As I mentioned, this is a fusion protein, and so this specific BiTE that's on the market right now is called blinatumomab. It is a monoclonal antibody, but rather than your traditional monoclonal that looks like that Y structure, in the lab they've taken pieces of two different monoclonals and fused them together in what really looks like a stick. Obviously the chemical structure is a little more complicated than that, but rather than your Y, that's going to be a monoclonal that attaches to a cell surface marker and do whatever. It's actually two pieces of two different antibodies fused together with a linker. So blinatumomab, why is it two different pieces? Well, it's one piece that targets the tumor B cell. So B cells express CD19. So CD19 is going to be the marker of the malignant B cell that the BiTE is going to attach to. And it's not actually doing anything to the B cell itself, it just attaches. But then the other half of the BiTE is a marker for a T cell. It's CD3, which is expressed on your cytotoxic T cell. So it's kind of this open marker hanging out on the B cell, the malignant B cell, saying, hey, come see me. And the T cell comes and attaches. So it's literally bringing the T cell to the malignant B cell and attaching it together. And then the T cell looks and says, hey, you're not normal. You're not like me. I'm going to secrete things and kill you. And so that's what it does, is it just recruits T cells directly to your malignant B cell. And so it's a fusion protein, so it takes the variable region of that CD3 to target your T cell to the variable region of a monoclonal for CD19, fuses them together with a linker, and it brings the T cell to the malignant B cell to kill it off. So obviously this therapy is only used for B cell malignancies because that's what the monoclonal specifically targets. You can't use it for anything else. So it's specific to B cell cancers, and it brings the T cell to the B cell and lets it kill it off. As kind of a modified monoclonal, we do have some specific toxicities to think about. So current BiTE therapies are known to cause CRS, which is cytokine release syndrome. We're going to talk about that in a second. It can also cause neurotoxicities. It used to be called CRESS, or cytokine-related encephalopathy syndrome. That terminology, as of literally last week, is going away. It's being redone. So I just put it on here because I'm waiting for that to all become official in practice. But it does cause neurologic toxicities that can be treatment limiting. And because it's directly killing off B cells, your tumor B cells and your regular B cells, you're going to have an increased risk of infection and hypogammaglobulinemia. Because remember, your B cells normally produce your antibodies, so you're going to have a reduction in that ability by targeting off your B cells. Any questions on this? The upcoming DART therapies are very similar to BiTE, but apparently their linker is much more stable, and so it's more effective at recruiting and keeping T cells there. But overall, the mechanism for DART is basically going to be similar to the BiTE therapy. So if those get on the market next year or so, you'll be familiar with it. So I mentioned we can augment internal T cells through vaccination. Unfortunately, this has been fairly limited in its ability to work in various cancers, or even in the ones it works in, it's limited in who is eligible and how much it works. These are all in solid tumors, so again, not my area of personal expertise. You'll get a little bit of this with your prostate cancer and your melanoma with Dr. Saunders. So I just want to introduce you to the concept. So there is a vaccine for metastatic melanoma, and there's also an immunotherapy product called Sipuleucel-T for prostate cancer that I have shown the process for invalidate tumor killing effect from your T cells being more activated through the external vaccination process. So we'll go more into that in detail, but unfortunately, vaccines really haven't been that effective, mostly because of the way the immune system can or the cancer cells can evade the immune system in your body. So augmenting that has been a challenge. So let's talk more about chimeric antigen receptor T cell, which is probably one of the hottest topics in oncology in the past 3 years. At the meeting I was just at, I think they said there are almost 200 ongoing clinical trials for CAR T right now, in a variety. It started out in hematologic malignancies, but now it's moving into the solid tumor world. This is something that is very exciting, and I think is really, we're going to see a lot more of it, but it's going to have broader implications in cancer care. The current 2 products that are on the market each respectively cost over $200,000 per patient. So obviously, as we do more and more of these types of therapies, how is our healthcare system going to accommodate this? That is a big problem that we're looking forward to having to figure out. So CAR T stands for chimeric antigen receptor. So it's a recombinant receptor. So we take a fragment of an antigen recognition domain and intracellular signaling. So if we look at the picture, normally our T cells have receptors that are going to recognize and attack whatever cancer cell. In this graphic, it's just a B cell. But they don't always work, and the tumor cell can downregulate them, or they don't necessarily always notice the abnormal cells. So there's a lot of limitations with our normal immune system in cancer therapy. So if we can take the T cells out of the body, and we can insert a chimeric antigen that's going to be expressed on the cell surface, and that chimeric antigen is specific to the antigen on whatever malignant cell, so in this case B cells, we can force the T cell to express the antigen to interact with the cancer cell and kill it off. So we're basically forcing it to recognize what we want it to recognize and target that specific thing. So a lot of problems with CAR T in the past were how do we get it to express enough of these receptors to work, and how do we make sure it doesn't express those co-stimulatory molecules that are going to downregulate its activity. So this has taken years of laboratory work to figure out. It's more complicated than I'm making it sound. But basically we make these T cells express the antigens we want so that they can more effectively attack whatever cancer cell that antigen is going to interact with. So the current ones on the market are for B cells, so they express and attach to CD19, as we mentioned with the BiTE therapy. CD19 is expressed on our B cells, so this is another B cell directed therapy that just happens to be what's made it to the market. Again, a slew of other antigens for other cancers are being evaluated right now, so this is going to change over time. This is just the current one. So we take T cells out of a patient, we augment them in the lab to express a specific receptor we want them to express, and then that receptor is going to attach to whatever cancer cell and help the T cell kill it off. So again, for the more visual learners, so how does this really work for a patient? So we take a patient to what's called pheresis, which is kind of like dialysis, but not really. We remove their white blood cells and we send them to a lab. The lab takes the T cells and tries using a variety of different methods. This is where it gets very complicated. I'm just going to skip over, it's going to take time. And make sure that it is going to express a specific receptor that we want it to express. This can be done by via transposons and retroviruses and using lots of different interleukins to stimulate and expand the T cells ex vivo in the lab. And this can take 1 to 3 weeks of processing and growth in the lab before we reinfuse it in the patient. So once we know that they have enough T cells that express that marker we've made them express, then we can reinfuse them kind of like a blood transfusion back to the patient, and we monitor for side effects and efficacy. So because there's a lot of lab work that's involved, and because sometimes it fails, we don't get enough cells or enough cells don't express what we want them to express, that's where the cost of therapy really comes in. It is quite complicated. It is very technical. And so that's kind of in general what happens here. So because we're giving these chimeric antigen receptor T cells, we're giving a lot of T cells to a patient that are very specific to the cancer cell surface markers. But we're giving T cells, and what do T cells do? Turn on the immune system. So yes, they're going to attack the cancer specifically because of the receptor they're expressing, but you're still giving all of this immune system immediately to a patient. That's abnormal. Our body isn't used to that. It doesn't know what to do with it. So we get these inflammatory immune responses. So CRS is cytokine release syndrome. We said that we saw it with the BiTE therapies. Again, we're turning on the activation of T cells through the BiTE molecule. We see even more of it with the CAR T. So this is the most common side effect to CAR T therapy because we're giving a bunch of immune cells all at once and the body's a little bit overwhelmed. So this is the immunologic response. So think about it. When you get sick and you have an immune response, what happens? You have a fever, right? So fever is the hallmark symptom of CRS. You cannot have CRS if you do not have a fever. That is a requirement. Most common other symptoms of CRS are hypotension and neurologic compromise. There can be many other organs involved, but the grading system for CRS is based on hypotension and neurologic compromise, just so you're aware. I'll test you on that one. In general, I want you to know that. So how do we manage CRS? Well, if it's an overactivation of the immune system, we need to turn down the immune system, right? So can we give corticosteroids? Can we block the chemicals in the body like IL-6 that are causing this excessive reaction? So there are algorithms, and there are actually a couple of different algorithms that conflict each other that are out there because this is a new therapy. Different hospitals have done different things in their clinical trials. So we're trying to kind of figure out still in practice how to put all this information together for these products. So this is, again, an evolving field, so I just left it pretty generic because I think it's going to change over time, and I don't want you to learn something and then have to relearn it later. But supportive care is important, and then again, kind of dampening the immune response if this happens might be necessary on patients with severe CRS. Any questions on CAR T therapy? We're going to talk a little bit more about it when we get to ALL and lymphoma, but I wanted to give you a lay of the land first. Okay, some other general things. So there's a lot of terminology in oncology. I'm not going to read all the rest of the slides, but you should kind of read them and be familiar with it. So we talk about curing patients, people that are in remission, people that respond. Those are all different things. Those terms don't mean the same thing, and we need to have a good understanding of what that means. So if you see, clinical trials or headlines or results of something out there, what does all this terminology really mean so you can put it in perspective? So adjuvant is following eradication of the disease either by giving radiation or surgery, then we give chemo after the fact. Neoadjuvant means we give the chemo before doing something like radiation or surgery. Salvage means you're giving something after failing something else, so that's a pretty easy one to remember. And then there's some different phases of chemotherapy, specifically for your heme malignancies. So induction is your initial chemotherapy to get that big debulking, so to speak, of the most amount of kill right off the top. Then usually there's what we call consolidation or intensification, where we continue to give chemotherapy even though they're in remission, because again, we killed some, but we haven't killed all. There's microscopic disease left that will come back if you don't continue to give chemotherapy to kill more and more and more of what's left. And then maintenance can be done for a prolonged period of time for some diseases. And I'll introduce the concept of measurable or minimal residual disease, which is MRD. So measurable residual disease is MRD. This is an emerging thing in our heme malignancies, to where we may have people, quote unquote, in a remission. We don't detect disease. But we're coming up with better and better technologies to look more microscopically in the blood, and we can find a few stray cells, 1 in 10,000, 1 in 100,000. That doesn't sound like a lot. Over time, that can cause a relapse of your cancer. So being able to measure smaller and smaller and smaller, we're able to know if people are more likely to relapse or not, and maybe have early intervention, maybe prolonged maintenance, or give other more frequent monitoring to start therapy earlier. So measurable residual disease is becoming something in heme malignancies, because even though someone's in a remission, doesn't mean they're cured. They can still relapse, and a lot of patients do relapse, and it's because those microscopic cells are left, and they're going to come back. There's other terminologies about dose-limiting toxicities, maximum tolerated dose. You should be aware of that probably from previous lectures and other courses. Dose dense means trying to stack your tumor kills. We'll go back to that dose curve. So putting them back to back to back, you hopefully kill more and more and more closer together if you can. So that's dose dense regimens. That works in some cancers, not others. So you'll hear about that in some future solid tumor lectures. So assessing response is quite complicated. It's different for every single disease state. But I want you to have a general understanding of how we assess solid and liquid tumors. And unfortunately, some of the assessment is impacted by the mechanism of the drug, and that's why I'm pointing out for you all. You're not going to have to go in and assess someone's CT scan and tumor size as a pharmacist, but you have to understand when they're talking about it what's happening. So some drugs actually cause tumor someone with melanoma that's on a CTLA-4 inhibitor. So you can see from baseline over time, they got worse before they got better, and that's okay. So sometimes the size of the lesion is not the be-all, end-all anymore. And the same thing can happen with some of our heme malignancies. So there's a drug called ibrutinib that we use for chronic lymphocytic leukemia, which the picture on the right is showing. These patients have an increase in lymph cells, which normally would confer a worsening of your CLL. But that's because it's actually mobilizing the cells out of the spleen, liver, and tumor node into the bloodstream, and then they're dying off. So a small transient bump is actually the drug working. So as we understand drug mechanisms, our assessment sometimes has to change. I'm not going to test you on this slide. I just wanted to use it as examples so that you can kind of understand that the mechanism of a drug and how we assess response are directly correlated. And so knowing how drugs work can help you interpret how a patient's doing, or ease a patient who's like, oh my gosh, my lesion's so much bigger, I should stop this therapy. It's like, okay, let's calm down and talk about this. So you can really help people feel more at ease with what's going on, and reduce the patient's level of panic by explaining some of this in patient-friendly terms to them. So solid tumors in general, as I said, are sized based on the target lesions, the tumor size, which we can do scans like CTs and MRIs to actually specifically measure their tumor bulk. Again, sometimes we have to modify this if they're on immunotherapies. But what we call the RECIST criteria is based on the size of the lesion. So we'll talk about complete response, which means all the lesions are gone. Partial response means they've decreased by a certain amount. Stable disease means they didn't meet the other definitions. And progressive disease means, oops, it got bigger. So those are the terms just in general. I want you to have heard them because you're going to hear a lot about CRPR, PD in the future. And for solid tumors, this is what they mean. Now, exactly how much decrease or increase is all tumor specific, and I don't think you need to know that, but in general, you do need to know this. For heme malignancies, everything is different. So each one is staged and assessed differently. So I've just, in general, kind of lumped them together for your reference. So lymphomas are based on size of lymphadenopathy and organomegaly, as well as the resolution of the abnormal cells in the blood, or the CSF, depending on where the lymphoma is. Myeloma is mostly based on the abnormal percentage of cells, as well as what we call serum and urine light chains, and other laboratory markers, so it's a little more complicated with some biomarkers. And acute and chronic leukemias is mostly based off the percentage of abnormal cells in the marrow, but again, that measurable residual disease is starting to emerge in heme malignancies, so you can meet response but still have MRD positivity, meaning, hey, you met response, but you still have microscopic disease left, and you don't really know what to do with those people. That's an emerging science within oncology care as well. And then there are some specific diseases that have certain mutations. So like the Philadelphia positive ALL and CML, we quantify the BCR-ABL levels, and we're going to talk about that in those lectures, so don't worry about it now. But I just wanted you to realize each disease is kind of assessed a little bit differently, but your solid tumors is mostly based on the tumor bulk and size. So we have just a few minutes left to kind of do some in-class assessment. I'm not going to call on specific people or anything, but I'm going to hopefully rely on some volunteers to call out some answers so we can get through this. But these are the kind of types of general information and questions that you might see on the exam. So I tried to highlight the most important pieces for you throughout this lecture. I hope that was helpful. So what are two of the ways a proto-oncogene can be activated? What do y'all think?
Point mutation and gene amplification.
Excellent, thank you. So point mutation, gene amplification, or gene rearrangement, so translocation or transposition, leading to a mutant fusion protein is the third way. So excellent. Which of the following is a tumor suppressor gene? AKA not a proto-oncogene.
P53.
Someone here in Augusta yelled P53 and they are correct. Good job. Which of the following is a pro-angiogenic factor?
VEGF.
Someone here in Augusta said VEGF, which is also correct. Good job. Okay, alemtuzumab is a monoclonal antibody. What's its target and what is the source of the antibody?
Tumor.
That's a mumbling True or false, an ECOG performance status of 1 correlates well with a Karnofsky performance status of 40. A lot of false here verbally in Augusta, which is correct. So remember, ECOG is 0 to 5, and Karnofsky is 0 to 100. A 0 of ECOG is equivalent more to 90 to 100 of Karnofsky, and those are both straight good functional status, versus a 5 of ECOG and 0 of Karnofsky is dead. So which of the following is not an agent which affects the microtubules? So someone here in Augusta said etoposide, which is correct. Okay, so here are some classes of agents, and the question is, which ones are cell cycle specific and which are cell cycle non-specific? So Vincas, specific, right? Because they're microtubules. Taxanes, specific, because they're microtubules. Oh, well, I thought I had these individual, but I don't do so. The antimetabolites are also specific, right, to the S phase. And then your alkylating agents we talked about are non-specific because they cause those cross-linking of your DNA strands, which doesn't require you to be in a specific phase for. And what are the agents in each class? I've listed here. Again, you don't need to write this all down. It's all in the lecture specifically. These are just some test your knowledge. I highly recommend for things like this, flashcards. I know it's just rote memorization. It can be very boring. But what are the classes? How do they work? What are the drugs? And what are the couple of main side effects I pointed out for each one? That's all important information, and you just gotta, unfortunately, just go through and memorize it. So I try to distill it down to the most important and focus on the ones I wanted you to really know that you're going to see in multiple future lectures. So I hope that was helpful. Okay, so matching each drug with its most common or class-specific adverse drug reaction. So pembrolizumab. What would be one of the ADRs off this list that you would correlate with pembro? Albany or Savannah, you want to give us a shout out?
Infusion?
So you can get infusion reactions, but there's actually one off the list that's much more class specific. So pembro is a PD-1 inhibitor. So what might be a more class specific ADR? You can phone friend.
Is it immune-related adverse events?
It is, good. So our PD-1 and our CTLA-4 inhibitors, pembrolizumab and ipilimumab are IMAP. Good. So what about blinatumomab? What would be one of the ADRs for that drug? Anybody?
CRF?
Yes, CRF, good. CAR-T,
CRS.
CRF again. What about cetuximab? The monoclonal antibody, and it's XI.
Infusion reactions?
Good. And then lastly, IL-2. I know I said I wouldn't test you on it, but I feel like it was an important one because capillary syndrome is potentially fatal. So I put that one in here just to give you an interesting one. Excellent. So those were all of the test your knowledge. I know we're running out of time, but I did want to put this up because, again, this isn't going to be a case-based section. I focused on the drugs that I wanted you to know their mechanism and toxicity. So for the miscellaneous agents, targeted at endocrine therapies, and the few biologics like IL-2, I don't necessarily want want you to memorize all of those. They may be discussed briefly in future disease state sections, but for the immunotherapies, the monoclonal antibodies, and the cytotoxic, cell cycle specific, and non-cell cycle specific agents, you do need to know their targets and their adverse drug reactions that we talked about in this lecture. So I tried to pare down what's more testable so that you're not overwhelmed with what you're studying. The chemotherapy classes, again, what's specific and non-cell cycle specific? What are their mechanisms and targets? What are their common adverse drug or class reactions? The immunotherapy mechanisms and ADR. So if I say which of the following, is a BiTE therapy, or which of the following correctly explains how CAR T therapy works, or this is the monoclonal, what is it to target, or what's its source, or what are the main side effects from CAR T therapy, you should be able to answer those kinds of questions. The background material about, not about the drugs, but the other material we went through that I highlighted is also testable, and I tried to verbally tell you what was just illustrations and examples so that you, again, don't waste time on those. But the background material, what can cause cancer, and what are proto-oncogenes, and how do they function, or how can they come about, all that kind of material is definitely testable as well. And then because this is rote memorization, either you know it or you don't, there are some multiple MATLAB format here. So, 1, 2, 3, 4, and then pick 1 or 2, and 3 or 4, and 1, 2, 3, 4, that kind of format. You're definitely going to see that on this section. So I just wanted to, I know you see it elsewhere in this type of class, but I wanted you to know you're going to see that on this section. So be prepared for that. You really have to know the material to get the right answer. You can't really guess in that format. Any questions about testable versus not testable? I know it's a lot of information, but it really sets you up for the future sessions to really understand those disease states and our